Thank you very much. Thank you for the invitation. Good afternoon, good evening. I'd like to present case of uncrossable lesion in heavy calcified right coronary artery chronic total occlusion retrograde PCI. And this is the clinical representation of the patient. It's 78 years old male with CCS class 3 post MI and PCI of a lady 8 years ago. And after 4 unsuccessful attempts of right coronary artery chronic total occlusion, and finally qualified to coronary sinus reductor to reduce ischemia with heart failure with reduced ejection fraction 30%. As you can see, there's hypokinesis of all segments and akinesis of basal segment of inferior and posterior wall. However, the viability was confirmed in MRI of the segments. So in angio, we had mid-RCA occlusion with partial antegrade flow through collaterals and one antegrade collateral to closed side branch of the margin of RCA and retrograde flow from septals and epicardial collateral. But the clue of this case were extremely massive calcifications in right coronary artery and body of CTO. So here you can appreciate the collateral, septals, and epicardial. So in JCTO score, there were 4 points, progress CTO risk of complications score 3 points. However, we know that there's no score that fully reflects the complexity of CTO cases. In JCTO score, we have no distal vessel assessment and collaterals, for example. So after short antegrade wire escalation unsuccessful, I changed strategy for antegrade dissection and reentry, and we had here base technique, and I tried to perform the knuckle. But the problem was resistance of calcified lesion, as you can see. And another problem was that direction of the knuckle was going to side branch all the time. So I changed the strategy for retrograde. This is the passage of septals. And tip injection from retrograde microcatheter to understand well the CTO anatomy. And the next problem was stop of retrograde wire. Anyhow, if we tried to go intraplaque, which was completely impossible in this situation, or extra plaque with knuckle, it was not possible. So I tried the retrograde Carlino technique. So I gave a little contrast intraplaque to make the easier way for the wire, for the retrograde wire, and it worked. Then I started the first reverse card, but it was completely unsuccessful. So because there were so massive calcifications, it was very hard to connect the extra plaque space of antegrade with retrograde extra plaque space. So I tried next base technique, trying to find new space. But the problem was that the knuckle was going always in direction of side branch, not in the architecture of main right coronary artery. So with patience, the next base technique, and trying to, because of bending and calcification, the knuckle was going always to the side branch. And in this time, you can see that it's going in the right way. And I performed power knuckle with inflated balloon and microcatheter. And you can see the knuckle is going in the architecture of RCA. So reverse cart in the new place. And after this, it was possible to progress the retrograde wire, a gladius wire, to aorta. So in the next step, I progress microcatheter to aorta and exchange wire for RG3. And snare RG3. Of course, this is the indication that we can snare a long wire, best RG3, not a short wire. And then externalization, and we had the right coronary artery and left system on RG3 with big support. However, it revealed that it's still uncrossable lesion in the body of CTO. So I tried 1.510 balloons, but it was unsuccessful. And finally, I tried Alveo 0.75 and it passed. So after this, and after inflation of Alveo, it was possible to perform predilatation and stenting. And this is the final result. So in conclusion, the 0.75 Alveo balloon is very valuable option in uncrossable lesion. Of course, there are some other options, better support with anchor, with guide extension, rotablation or orbital atherectomy, as we mentioned, and from my experience, orbital atherectomy is a little less efficient in front uncrossable lesion. Granuloplasty, sometimes it's a good solution. Of course, microcatheters like Tornus, Tarpane, Gold. External crutch, very valuable but very rarely used option. I presented the case with external crash in uncrossable lesion on a BrosMed webinar several months ago. And of course, completely out of standard possible use of external lithotrips. Another conclusion is that massive calcifications can be a very big challenge in reverse cart because of limitation of possibility to connect the retro and antegrade space. Thank you very much.
Congratulations for your great case. Probably I missed something, so I would like to ask you that why did you do the retrograde Cardiology instead of going directly to the reverse cart?
Yeah, because it was impossible. If you can see, the microcatheter was just banded in the calcium. It was impossible to go directly with wire, even if the wire was stiff like Gaia Third. And first I tried to go maybe intraplaque, but it was impossible. So I tried strategy for perform knuckle, retrograde knuckle, and going extra plaque, but it was impossible too. It was too less support in this massive calcifications. So Cardiology made the way for the wire easier. Yeah, and that's why, of course, it was not the reason of the final success, the Cardiology method. But I think sometimes if we have very massive calcifications, it's a good way to progress.
I mean, Cardiology is kind of almost the same as a granuloplasty. A granuloplasty, you put the balloon and you rupture it, so the injection goes from the balloon. Granuloplasty, you inject through the microcatheter. I mean, Cardiology. So it is helpful quite often if you're stuck with the heavy calcium. And one thing to mention, going back, I know it's about laser. I have used laser on proximal caps, impenetrable proximal caps. I just laser modified it completely and were able to penetrate with the wire after. So that, I mean, you know, modifying the cap and the calcium could be quite important to be able to complete your procedure.
And for the laser, you don't need to have the wire engaged. Yeah, this is the
Well, you know, these cases, hopefully I'll
yeah.
publish them soon. I've done it here without the wire because nowhere will go. So I just put it at the proximal cap, some contrast, and activated it, and then yeah, we were able to penetrate the cap. So it was without a wire. Yes.
Yeah.
You're muted, Dr. Damras.
Yeah, Professor, do you have experience with laser wire?
With laser?
Laser wire, yes.
No,
in the beginning,
no.
I mean, 20 years ago, it first come with laser wire and RF wire for CTO.
I think I've used, or I was still in training, and I've seen it used 3 times, the laser wire, and all 3 cases ended up with perforation. And I think this is why the laser wire has come out of fashion and it's not used anymore, because it's uncontrollable. But it is a very good idea. I think nowadays it's probably time to come back, because we're kind of, you know, in an area where our CTO skills have become completely, and you know, much more advanced, and we know exactly where we need to go. So I think a laser wire might be a good comeback.
Dr. Grzegorz, may I ask you, when you use your septal collateral channel, what is your tactile feeling? Because from angiogram, hardly see the septal collateral to the right artery, but when you manipulate, it's very easy. What is your tactile feeling?
Sometimes it's easy, sometimes it's not. You know, sometimes big septal is not easy. You know it exactly. We must just try. Yeah, but yeah, you are right, because there were not one big septal. What is I think the one or several big septals are the best solution for us, and not many septals that are tortuous but thin. Yeah, this is always the problem. But this case was really easy septal crossing, really, with normal Sion. And
do you do searching? I mean, try many septal.
No. I always try. I'll always try. Yeah. I always try surfing first, and the next, if it's not efficient, I try tip injection, and then trying with Sion Black or Suor. It depends on the collateral.
I mean, I think this case you could see couple connections, quite good.
Yeah.
Good connections. So you don't need to surf; you just go for it. But yes, surfing or
it was not looking like surfing here. It was just going.
Yeah. But obviously, it's one way of crossing the septals is surfing or tip injection.
So I have a question for the experts. Do you use often rotablation or lithotripsy in extra plug space? So in subintimal space?
Very good question. And for me, I have used rotablation. I still have not used IVL. I haven't used IVL in subintimal space. I have a little bit of reservation about using laser. I keep talking about laser now since you brought it up. But yes, I have used rotablation many times in subintimal space, but not IVL. On the occasion that I needed that, I thought there was still some difficulty. Once we've gone through the true lumen, I used the IVL in the true lumen after we put the stent in. But I know I'll be interested to hear the others' experience.
I have one bad experience with a laser, but it's eccentric laser. And by the time that I used it, we didn't recognize that the nurse passed the eccentric laser to me. When I lacing his big perforation.
Yeah. Well, luckily the eccentric is not there anymore.
Put it away, yeah. After that, we put the eccentric catheter out of the shelf.
Yeah. It's not produced anymore. Anyway.
Same here. I have done the extra plug rotablation sometimes, but I have never had the experience about the IVL from the extra plug. It's not available in my country.
Okay. I mean, I think I have to say, for me, IVL, and I'm interested to hear your experience. I know there's a lot of noise about eccentric and about nodular calcium that IVL works. my experience, the cases that IVL failed have always been the eccentric calcium nodular one. And when you're thinking about using it in the subintimal space, you're always going to think it's always going to be eccentric. So I'm not sure if it is, but I'm sure at some stage somebody will use it and will come and tell us, yeah, you could use it. Or maybe if we have to and we're stuck, you might use it even normally and not deliver the whole train of pulses, just use a few to change it. But yes, I think with the eccentric calcium, that's where I think IVL still fails a little bit.
In my experience, IVL failure was in restenosis, but there were 2 layers of stents. And in one stent, restenosis, 1 layer of stent, it was completely efficient. But in 2 layers, there were problems. So
yeah, I mean,
maybe laser is a solution for this situation. Yeah.
If it is calcium that's causing the problem with the stent, then IVL will be good. But if it's not, then of course it's going to fail.
I have one more question, Professor. Why in this case you prefer to snare the RG3 than the retrograde CTO wire? Don't you afraid the RG3 will be broke when you snare into the guiding?
Normally, I snare, or I try to snare always RG3, because if you are snaring the shorter wire, it's for me it's maybe forbidden. It can cause much complication. So I think I never have problems with RG3 snaring, to say the truth.
Yeah, I mean, I'll just make a comment on this. I mean, the conventional teaching, particularly for if you're not as experienced in CTOs, is never to snare a short wire, because you could easily lose it. It could come through retrogradely and you lose it. And I know some cases, yeah, a patient had to go to surgery because the wire was stayed in. But that not to say once you develop the experience, and also you do not snare stiff wires. Because if you snare the stiff wire, they could get stuck in the guide catheter and become difficult to release. However, circumstances can be a little difficult and different, and you could do all this, but with experience that you have built before. I have snared Confianza 12, but what you do with the stiff wires, you snare them and you bring the microcatheter into the aorta, and you move your guiding catheter back to the middle of the aorta. Then you push the snare forward, so you release the wire. Then you take an RG3 and snare it. Going back to the question you was asking if the RG3 can be damaged, of course it can. You try to catch it or snare it at the soft part and not from the radioibic part, because the radioibic can break off and if it does get damaged, because it's 330 centimeter, you could cut that a little bit once you've come out and become straight and use it. But yes, stiff wires, short wires, be very, very careful of snaring them.
Thank you.